Good morning, everybody. Welcome to Internal Medicine Grand Rounds. I'm Dr. Skeest, and today we have an excellent speaker and topic. We have Dr. Daniel Engelman from the Department of Surgery, Division of Cardiothoracic Surgery. Dr. Engelman is known to most people here because he's been here for a long time. He got his medical degree from NYU, and then he did his surgical residency at University of Connecticut, where I just realized we overlapped for a while, looking at his CV. And then he did his fellowship at Harvard at the Brigham and Women's Hospital. And he's been, as I said, Baystate many years, and he's in many societies and many awards and many publications, and has been doing a lot of work on perioperative care, speaking all over the country and all over the world. And today he's going to talk to us about perioperative cardiac surgical care. So welcome, Dr. Engelman.
Thanks, Dan, and thank you, everybody. One thing we really lose with these virtual meetings is the interaction with the audience. So I would encourage this audience to feel free to use the chat box. I'm going to try to keep an eye on it and ask some questions, and we could even turn on some audio if we need to, if we have some engaging questions and people who have real things they want to add and maybe make it a little more interesting for people. I'm not sure how many people can actually see slides or are just listening to audio, so I'll try to describe slides if you happen to be driving or doing something else which prevents you from seeing the slides. But once again, any questions you may have, no matter how crazy they are, please try to type them into the chat box and I'll try to get to them. And we can sort of make this an open-ended discussion. So I'll begin right now. And what we're really going to talk about is standardizing evidence-based best practice in perioperative surgery, specifically cardiac surgery. These are my disclosures on the device safety medical expert for Edwards Life Sciences for transcatheter valves, which has nothing to do with what I'm discussing today. So I have no relevant disclosures. So I like to start most of my lectures off with this slide, and this was something that even though I've seen this 100 times, it's still hard for me to believe. And what it describes is we think that we can cure a patient in cardiac surgery in the operating room, but when they actually went back at the morbidity and mortality that followed cardiac surgery and looked at each individual case, it turns out that greater than 80% of the preventable morbidity and mortality occurred outside of the operating room. We're outstanding at fixing valves and doing bypasses, but we're not paying enough attention to the preoperative optimization of patients before surgery and the postoperative standardized evidence-based best practice. There's too much variability, which probably led to most of the morbidity and mortality in this particular study. And that's sort of what got me interested in trying to standardize best practice, because we really are standard with how we do myocardial protection in the operating room and how we do our surgery, but very non-standard in our practices for preoperative and postoperative care, which then brings me to ERAS. So what is ERAS? And ERAS is enhanced recovery after surgery. Maybe a bunch of you have heard about this, but it's sort of the standard practice now in Europe for almost all surgical practices. It started with colorectal surgery and then expanded to almost every other surgical subspecialty except cardiac surgery. We were the one specialty that did not pick up on this thing. And what these programs have demonstrated is by standardizing evidence-based best practice, they all show significant reductions in length of stay, blood loss, transfusions, time to ambulation, generalized complications, decreased readmissions, and increases in patient satisfaction around pain. So that seemed to be a good idea to try in cardiac surgery, and yet everyone said it wasn't possible. Now, it's not fast-track surgery. Now, coincidentally, I use this slide to sort of tongue-in-cheek because my father, who's also a cardiac surgeon, he sort of invented fast-track surgery. He's the first person that ever came up with that mnemonic. And this is the paper he wrote in 1994. That's my father on the right, myself on the left. I got to operate with him a bunch of times before he stopped operating. And what he wrote was that he could get patients out of the hospital much faster if he gave them a standardized group of interventions such as early extubation, steroids, atrial fibrillation stuff, a dedicated fast track coordinator, et cetera. And this sort of was the beginning to standardizing best practice following surgery. And I kind of, without even thinking about it, sort of picked up where that left off decades later. So as I mentioned, these ERAS protocols were successfully applied in other surgical specialties. Here's a standard colorectal ERAS perioperative pathway, which involves changing the MPO status, so feeding people clears right up until 2 hours before surgery, giving them some preoperative analgesics, giving them specific blocks, and then intraoperatively keeping them from getting too many narcotics, and then postoperatively watching their fluid balance and getting them out of bed quickly. And here are the major subspecialties that have picked up on that. But everyone said, well, it can't be done in cardiac surgery. Why? They said, well, this is why. It's too complicated. Cardiac surgery involves cardiopulmonary bypass, tons of transfusions, blood loss. We can't keep up with it. Temperature management. There's so much. It's so complicated. We can't standardize it. But it turns out that probably wasn't true. So in 2017, I got a group of like-minded surgeons and anesthesiologists together, and we had our first little breakout meeting, which was pretty successful. And then that kind of moved on to being anointed the official cardiac surgical ERAS society out of Sweden. We went over there and they anointed us and gave us that mnemonic and allowed us then to use their ERAS name and publish with their blessing. And then we developed multiple boards, which went on, and all kinds of experts we brought on board. And then we developed this mission to optimize perioperative care in cardiac surgical patients through collaborative discovery, analysis, expert consensus, and dissemination of best practice. So it was easy to make a mission statement. The hard part was actually publishing it, which we then began 2 years ago by using our standard Society of Thoracic Surgeons grading for class of recommendation and level of evidence for every particular recommendation we came up with. We did a Delphi analysis, went over and over and had everyone argue for months and months. And finally, then in August 2019, we did publish in JAMA Surgery our guidelines, which sort of put us on the books there, because suddenly we had standardized things, graded it, and come up with a consensus. So that was sort of a big milestone for us. And this is sort of a summary of the recommendations. We're not going to go through all of them, but you can see they have different classes of recommendation, different levels of evidence. And I mean, some are obvious and some are less obvious. There's no question you should use best practice and reduce surgical site infection. That's an easy one, but it's not as obvious, let's say, that you should be using rigid sternal fixation as a way to close sternums compared to wire cerclage or urinary biomarkers or all kinds of other little things we put on here. And we'll go through just some of the highlights in this talk. We also had a couple negatives, that you shouldn't strip chest tubes and you shouldn't let your patients get too hyperthermic after cardiac surgery. But be that as it may, so we started publishing. This is the first US-based ERAS cardiac results. And what all of the publications have shown the same thing, which is basically that if you follow the ERAS guidelines, you can decrease opioid use significantly after cardiac surgery. And this is a 40% reduction in the first 24 hours postoperatively, reduce GI complications during the postoperative stay, and decrease length of stay, which is significant. And over again, every study now has shown the same thing in both cardiac and non-cardiac ERAS. Here's the next one that was published. This one was by a group of anesthesiologists at Hopkins. And what they showed is that as they increase these process measures, which is the use of acetaminophen, gabapentin, which are sort of a multimodal non-opioid analgesics, using a protective lung ventilation strategy, and also regional blocks, that as they increase the number of these process measures, they were able to increase the percent of patients extubated less than 6 hours, and decrease their total length of stay. So the more of these process measures you did, the better the outcomes. So our society kind of got together and we came up with some potentially disruptive evidence-based recommendations, which at first made them uncomfortable at our national meetings, because this is not the standard way that cardiac surgeons have been practicing. One of the suggestions is that elective patients should be optimized with 4 weeks of prehabilitations prior to surgery. That's especially patients with malnutrition, hyperglycemia, anemia, frailty, and hazardous ETOH use or smoking. So that is not the way cardiac surgeons practice, and I'm sure a lot of you know that. We get a patient that seems appropriate for surgery, and we put them in the first available slot. We don't try to reverse their malnutrition or send them to a endocrine specialist to work on their high hemoglobin A1C, and we also don't do much about preoperative anemia other than tell them they're probably going to need blood in the operating room. But it turns out all the data is suggesting that if you address these things preoperatively, patients will do better postoperatively. Ending preoperative dietary restrictions is huge. We used to keep every single patient NPO until midnight, and yet their surgery could be at 3 o'clock the next day, which never was good. And it turns out by making patients NPO for a longer period of time, you increase their glucose variability. They require more insulin, and it does not help your hyperglycemia at the time of surgery. How we close the sternum was a whole other area because we used to just wire them all. Now it turns out rigid sternal fixation is probably a better idea. Reducing ambulation restrictions, chest tube management, AKI reduction, which I'm going to discuss. And it really comes down to thinking that maybe perioperative medicine should be its own specialty, its own individualized area of expertise that probably needs more attention, more research, and should be a mixture between anesthesiologists, critical care doctors, and surgeons. And we're also looking at patient-centered value. What is patient-centered value? Well, that's the patient-reported outcome divided by the cost. And the core principle is that we need to standardize evidence-based best practice to reduce all of these bad outcomes and also decrease the overall cost of the care, which would then increase the value to both the patient as well as to the providers in the hospital. And I put the slide always up because I want to remember that the nursing component is huge when it comes to enhanced recovery, because the nurses really are the frontline providers. They're providing a lot of the care, and they also are taking a big role in enhanced recovery. They like it, they understand it, and they really are the bridge in doing all of the work. And they all in our enhanced recovery after cardiac surgery did make the cover of one of their journals, which was important. So this comes from Wake Med, which is one of the first publications on ERAS cardiac, and it divides it up nicely, this slide, between the pre-op components, the intra-op, and the post-op, which really shows you there's 3 separate areas you need to attack when you're doing an ERAS cardiac or ERAS any surgery protocol. And it involves a lot of education before surgery. All the things I talked about optimizing nutrition, stopping smoking, stopping drinking, at the day of surgery, not making the patient NPO, letting them drink those carbohydrate-clear drinks right up until surgery, or at least till 2 to 4 hours before surgery, and then giving them some multimodal analgesics before surgery. Intraoperatively, decreasing the amount of opioids that we're giving, watching their temperature management, and then postoperatively continuing those multimodal analgesics and not giving them a huge amount of opioids, extubating them early, getting them moving early, getting the lines out early, and then getting them home and not having readmissions. There's another slide, basically just summarizing the exact same thing I just discussed in a little bit of a different detail. I'm not going to go into it. I want to pause right there and let anyone ask questions they want through the chat box, or even unmute if they want, about the overall ERAS ideas, protocols, anything about that. I'm pausing for a second, and if no one has any questions, I'll proceed. Feel free to unmute and ask your questions. I'm happy to hear anything. So Jim Freeman asks, why is rigid sternal fixation and why is it better? Excellent question, Jim. Thank you for asking. So wire cerclage basically just wraps the 2 pieces of bone together, but it does not prevent the 2 pieces of bone from riding up on each other. So easily by the end, one can end up higher than the other or separate. It loosens much more readily than rigid sternal fixation. The most bone in the world on a daily basis is cut by cardiac surgeons, not orthopedic surgeons. And no orthopedic surgeon would ever put 2 pieces of bone together without screws and plates. They would never wire them together. Hence, the best way to do this, it turns out, probably is rigid sternal fixation. Why not do that on every patient, one might ask? Because it's very expensive. It's a few $1,000s to use this piece of technology. Despite the fact that there are 2 randomized controlled trials showing better outcomes using rigid sternal fixation, it still is not widely used in the general population. Other questions? If not, I will proceed. I picked 3 areas of highlight that we're actually doing at Baystate Health that we're really taking the lead around the world to discuss and delve into a little bit deeper. The first is on opioid reduction. And let's see. It says for some reason Victor can note, and now I can't. Now I can't move my slides forward. Anybody?
Well, do you still have that message in the middle there? We should just dismiss the annotation request if you see another one. But if the request is still there, you can dismiss it. Otherwise, maybe just click on the slide and then try advancing.
Nope, frozen. Victor appears.
Sorry, let me just sign off and see whether that will let you move forward. I had only one question about the chest tube management, and I will sign off. Sorry.
Yeah, no, that's fine. Let's have you ask about chest tube management while we figure out how to get you to not run the slides. Suggestion? I can stop sharing and restart. How about?
Yeah, well, I think he had requested permission to annotate, and it must have been granted. I'm not sure how to dismiss it after that. I mean, I assume if you go back to sharing now, you'll be all set.
Sign off. Let me just come out. And then
Yeah, Victor, you should be okay. You hang tight and go ahead and share your screen again, and we'll probably be fine.
Yep, we're good to go. Victor, what was your question?
The chest tube management that you mentioned, I wasn't totally clear. What was that about?
Yeah, so actually, the chest tube management one is specifically in our guidelines says that you shouldn't strip the chest tube. So if you think they're clogged, stripping them is dangerous because you put so much negative pressure on them, you can pull off a graft. In addition, it says that you should do whatever you can to keep your chest tubes patent. So that can either be technology which automatically goes in the chest tube and clears them, or it should be better placement or better sizing of chest tubes, which keeps them patent. But other than that, there are no real specific recommendations.
Okay.
In guidelines. Though a lot more work needs to be done because every heart surgeon in the country or the world puts different chest tubes in different locations and leaves them in for different periods of time. So we definitely need to standardize better practice. By the way, just as an aside, the only data ever showing you when to take a chest tube out after cardiac surgery is not the volume that comes out, but the consistency. When it turns serous, they're ready to come out. It doesn't matter how much they're putting out. If they're serous, they can come out. But that's just an aside. So let's talk about opioid reduction. So it turns out that 1 in 10% of patients after cardiac surgery are still filling opioid prescriptions 3 months after surgery. Theoretically, they're at high risk for long-term narcotic addiction. These are patients who have not previously taken opioids prior to their heart surgery. So the risk is we are actually potentially making opioid addicts out of up to 10% of our cardiac surgical patients. This is horrible. It's a healthcare crisis. We need to do a better job. So that's the problem. Now we're going to talk about what we've done about it. The goal here is to get as many surgical patients as possible discharged without any opioids at all. And in order to do that, we need to taper their opioid use during their postoperative period, and we need to give them more multimodal analgesics. These are drugs that are non-opioid, of which we have some, but not as many as they have in non-cardiac surgery. And that's because we can't use non-steroidals after cardiac surgery. After orthopedic surgery, colorectal surgery, they give non-steroidals liberally. We cannot because of warnings on a lot of these COX-2 inhibitors after cardiac surgery. So we're limited to things such as gabapentin, maybe muscle relaxants, a lot of Tylenol. But nonetheless, we still should try not to give as many opioids. Hence, the problem we don't really know how many opioids we're giving patients after surgery. And that's because on a daily basis, we don't know how many MMEs are being utilized. Those are morphine milligram equivalents. So I asked my pharmacist, how many morphine milligram equivalents have I given this particular patient in the last 24 hours? And they need to break out a spreadsheet and a calculator and type and type and type and look at all the MARs. Very complicated problem because they can't do it right there, and they can't graph it over time to see if we're actually de-escalating MMEs. Hence, instead of doing it that way with a calculator and opening the MARs, we have developed an electronic health record automated system built into our medical record. We came up with this idea and worked through TechSpring with them to develop this, which in real time allows us to graph morphine milligram equivalent usage during rounds. And this is a sample screenshot that we use in real time. It's being beta tested. And in the middle here, you can see the daily MMEs being used, and you can see it de-escalating down to the preferred level right here and then off. And once it hits around here on this day is when we need to discontinue them. We need to get them off the MAR, because as every physician knows, if it's on the MAR, some nurse may decide to start pushing the OxyContin 2 days after the patient's ever had one, despite the fact that they could instead be taking a non-opioid drug. So that's the first thing, is we can graph our MMEs. The second part is we get a total MME on each day and figure out the breakdown. What are those MME drugs? Which are the ones that are opioids, which are non-opioids? Here we have the multimodals for that patient. So I can quickly look down that list and say, wow, why don't we have gabapentin on that particular patient? Let's add it, or let's add, make sure they're getting around the clock acetaminophen. So it's actually sort of a checklist there of the non-opioids. And then the third is that we can de-escalate them. And here we can go back and see if someone has a lot of opioids. We click on that little dot and we can see the breakdown. Here's what the patient actually got. They have a PCA, they have some fentanyl, they have some OxyContin, and we can actually decrease individually what they're on and de-escalate their MME utilization after surgery. And this is all timed based on when their surgery was. We can see it on this spreadsheet. So we've done a initial use assessment of this particular beta product that we developed, and we looked at patients that had what we consider to be the standard of care on the left, and then 25 patients after we started intervening, and compared the two. And we looked at the daily mean MMEs prescribed at discharge, and you can see we have about 1/3 the amount of MMEs on discharge, and the percent of patients prescribed any MMEs, that's any opioids at all at discharge, went from 84% to 44%. So dramatic decrease in just 25 patients. So we believe by having greater opioid MME situational awareness, it can guide our treatment algorithms and decrease the amount of opioids given postoperatively and upon discharge, which will then decrease the percent of our patients who are persistent opioid users at 3 months. And where we're going with this is actually trying to take it to the next level with CDS, clinical decision support, where we provide opioid de-escalation scenarios and recommend non-opioid alternatives, and then tie it to the assessments by the patients of their pain. So we can actually say, wow, this patient's getting all these opioids, but they have no pain. Maybe we should be de-escalating quicker. So there's all kinds of plans with this. And this actually is going to be marketed nationally and sold to other hospitals through an alliance with a third party and through TechSpring. So we think it's pretty exciting. And every hospital that I presented to said, wow, this is the missing link. This is what I need. So it's very exciting to cardiac surgeons. I'm going to pause there a second, let you guys unmute. Hopefully Victor won't steal my slides this time, and let you ask some questions, please. I see Carol saying the type of view of opioid use would be great for all hospital patients. Completely agree, Carol. Great question. And it will be available to all hospital patients. We're the guinea pigs, and it's sort of like we were the guinea pigs for Praxify, and now it's available for all patients. So we just work closely with TechSpring, and it will be widely available. It'll be it's already on all of our computers, where we can actually just click it and look at the opioid utilization. I agree. This is not just for cardiac surgery, not just for surgery, and not just for any patient population. It's anybody who's on opioids. We need better situational awareness of the MME utilization on a daily basis. Dr. Skeest asked, how do you handle patients with prior opioid use or addiction? That question I hate because I don't know the answer. Great question. I've actually purposely not included these patients in our cohorts in our study because they are such a different group of patients. They require such a multimodal pain service, addiction service, psychiatric, behavioral intervention that I think for the time being, I cannot answer that. But it's a huge problem. Completely agree with you, Dan. How quickly have you seen patients come off opioid use at all with 2 days sooner? So I have peers at other institutions that send pretty much nobody home with opioids. So it's absolutely doable. We've used more regional blocks now after cardiac surgery. So we're injecting patients right after surgery with these regional blocks, decreasing their opioid utilization. And we are then finding that we can, I would say with half of our patients, get them completely off opioids within 2 to 3 days. Does this tool incorporate drugs like methadone, Suboxone? Absolutely, because those all are, they have MME equivalents and they are absolutely included, and they are important because they're hard to calculate and figure out what their MMEs are, and they are absolutely built right into that. Yes.
Do you traditionally stop narcotics after 24 hours?
No, absolutely not. No, traditionally we continue narcotics through discharge and handed people what we used to call a just-in-case prescription. Just in case you get pain when you get home and start doing more work, lifting things and doing things. We don't want you calling us at 2 a.m. Here's a prescription for some OxyContin that you can leave in your medicine chest and have your family members find in a few months. That was the standard of care. It's horrible. We need to stop that. That can't occur any longer.
Which is such a reduction. It's like it almost 200%.
Yeah, I mean, these are very little ends. I'm not going to put much weight on it. All I can tell you is that we are sending home much less opioid prescriptions, less quantities, less patients receiving them, and a lot of patients by day 4 are on no opioids. It's my standard on rounds to ask, how is your pain? Turn to the pharmacist that rounds with us and say, how many MMEs did they get in the last 24 hours? And routinely the answer is none. And then I discontinue all the opioids from the MAR. That's the important part. Leaving it on the MAR puts them at risk of getting the drug back. So instead, get it off of there. That's the intervention that I like. Any other questions on opioids? It's a key component of all ERAS protocols, switching from opioids to multimodals and regional blocks. So that's why I kind of like spending a little time on this. All right, we're going to move to the next slide. Let's see here. Patient engagement, also a key part of all ERAS protocols. So what we use is something called Seamless MD. I'm not sure how many of you are aware of this, but it is an informatics solution which is available now at Baystate Health. And what it is something that resides on either the patient's phone, the patient's computer, the patient's iPad, and then we also can engage with that on our devices. And it educates patients starting preoperatively through their hospitalization into the post-op timeframe. It tracks their PROs, and if everybody I hope knows what a PRO is, that's a patient-reported outcome measure, which is very important to define how the patient perceives their care and how they heal from their surgery. It monitors them post-operatively to reduce readmissions and lengths of stay. We have real-time dashboards to get feedback from our patients, and we integrate this into our Cerner system. So, for instance, we can get the pain scores from this app and then tie them to the MMEs that we just heard about from the other app and put it into one big package. And now we've teamed up. On this slide, there's only a total of 3 hospitals, but we're with 5 hospitals total, where we have monthly meetings virtual with these 5 hospitals that all are using the same patient engagement app following cardiac surgery. We're asking the exact same questions of our patients pre, intra, or perioperatively, and then we can track and compare our outcomes. So we see better practices from other hospitals. We can use their best practice to improve ours. And what we've seen is decreased length of stay, decreased readmissions, and decreased discharge to a skilled nursing facility. So more and more patients being sent home versus a SNF. So we're using this multi-site collaborative as part of a quality improvement initiative in order to benchmark these things and improve each other's outcomes. And you can see that we're improving early mobilization. We are, in this particular one, this is just from our data over 1 year, we found that by using this in a couple hundred patients, comparing patients who used it to patients who didn't, we found a 72% decrease in readmissions, a 69% decrease in the observation stays where they come back overnight for a night, and a 13% decrease in ED visits. We actually have the lowest readmission rate we've ever had since we started counting this in 20 years now, which is about 5%, while the national standard is 10% for readmissions within 30 days following cardiac surgery. And we think a lot of it is due to the use of this app. And this, as I was talking about opioids, this ties into the opioids. So the patients are asked, you can see on this slide, which medications did you get on discharge? So they click, I got OxyContin, I got Tramadol, I got whatever they got. And then they ask on a daily basis, how many did you take yesterday? So they click it. So we can actually then try to trend who's using a lot of opioids on discharge for those few patients that are still getting opioids on discharge. And then we correlate that with their pain assessment and then go back into our MME app and try to make assumptions to who got pain meds and who didn't need them, who needs more, who needs to come back to the office to figure out why they're still taking so many opioids. So we're really trying to get on top of this opioid epidemic. I'm going to pause there and talk about patient engagement through this app and see what questions people have, either through the chat or jump right in on the phone. Have any of you ever heard of this particular app, Seamless MD? It doesn't sound like it. So it's really set up only for ERAS program. So really it's more of a surgical app. It should be probably rolled out to our other ERAS programs, such as the colorectal ERAS, a thoracic ERAS, other surgical subspecialties, because it's really set up for that. But it does seem to pay for itself in spades if you can reduce readmissions. And now our last topic. Here we go. Katie says, many patients do not have access to this technology. What do we do for our lower literacy patients? Great question. So it's built on sort of I think a 6th grade level reading, though you're correct that it won't work perfectly. We do have it in 2 languages. We have it in Spanish. That's good. And pretty much everybody nowadays, especially with the pandemic, appears to have access to a smartphone or a computer. So that problem seems to be we've overcome. Plus, we also have 10 iPads that we can give out to people, these sort of knockoff iPads, and they can use them in the perioperative time frame and take them home and then bring them back. So we've tried to get over the fact that some people don't have the technology. But great question. Is the app communication going to a nurse or direct to the surgeon? It is definitely not going to the surgeon. And that's important. Great question. It actually goes to our nurse coordinator. We have an ERAS coordinator who coordinates everything pretty much, not just ERAS, but everything cardiac surgical. And she is the one that gets the communications and then gives them back to me. What's interesting is after surgery, the patient can answer the questions. So before I walk in a patient's room, sometimes she'll whisper in my ear and say, this next patient you're about to see feels as though they're not getting adequate education surrounding their medications, or is feeling too much pain, or is complaining about something. And it's sort of like a hidden little secret way into their brains without actually talking to them about it. And I walk in blindly, don't tell them that I've read it, but I just start, asking questions specific to their problem. So it actually works pretty well as a way for patients to express their concerns without having to tell you face to face. But great questions. All right, my last major topic, as my Siri phone starts talking. My last major topic is AKI reduction. This is something I'm specifically very interested in, and we've done a lot of work at Baystate Health on, so I'm going to focus on this for the last topic. So I published these two manuscripts in the last, I don't know, 3 months. And they're in our two cardiac surgical journals. One is utilizing urinary biomarkers to reduce acute kidney injury following cardiac surgery. And the other is stress biomarkers do not correlate with risk factors for kidney injury following cardiac surgery. So I'm basically trying to change the way we take care of all cardiac surgical patients in the world through the use of urinary biomarkers. So to give you a little bit of background, so AKI is defined internationally by KDIGO definition seen on the left, and the stage 3 is considered when you have a tripling of your baseline creatinine during the first 7 days after your cardiac surgery. The cardiac surgeons are only concerned about KDIGO stage 3 because that's all that gets reported to the Society of Thoracic Surgeons website as AKI. So that's really the marker. That's the one they care about, the tripling of your creatinine after cardiac surgery. That's sort of the background here. However, cardiac surgery is associated with a crazy amount of both mild, moderate, and severe AKI. Severe AKI is the tripling. A moderate AKI is a doubling of your creatinine, and a mild AKI is an increase of 0.3 of your creatinine after cardiac surgery. If we take all cardiac surgical patients together, we can see there's a 57% of our patients don't go into AKI, but 43% do, with 22% stage 1, 13% stage 2, and 8% into stage 3. That's all comers. It's a little less if you're doing isolated CABG, and it's more if you're doing a higher risk cardiac surgery. So it's a major problem after cardiac surgery. And as you can see in this slide, the readmission rates go straight up exponentially with any AKI after cardiac surgery. Mild, 16% readmission rate, moderate 21%, and severe 29% readmission rate. So that's not good. And even a small bump in your creatinine of 0.3 seen on this slide increases your mortality after cardiac surgery. That's a 0.3 bump, which is stage 1 AKI, that then reverses back to normal before they're discharged, increases mortality by 10%, which cardiac surgeons have no idea. And it's these life tables that really explain it. And they show that as you have increasing AKI over, this is 3 months, you have a 6% increased mortality, 22%, then 36%. So you've gone 4x up to 6x increase in your mortality if you have stage 3 AKI within 90 days after cardiac surgery. But it's not just reduced short-term mortality, it's also reduced long-term mortality seen in this study over 10 years, where the more AKI you have, the shorter your lifespan. People ask me all the time, why is it that a transient bump in your creatinine after cardiac surgery results in decreased lifespan? And the answer, the nephrologists tell me, is because it's increased your risk of CKD, chronic kidney disease, by having that particular bump in your creatinine after cardiac surgery. So what do we do? What we decided to do was go after this urinary biomarker called NephroCheck, and it's a combination of two elements, these TIMP2 and IGF-7, which are cell cycle arrest markers that are given off during kidney stress. The multiplication of these two things, TIMP2 and IGF-7, gives you a excellent idea of the stress of a kidney before it's actually been permanently injured. And based on this study that came out just last year, the peak of this after cardiac surgery is 6 hours after ICU admission, continuing on into post-op day 1. Based on this, we decided in every cardiac surgery patient, we would measure this particular biomarker the morning after cardiac surgery. So that's the background. And we developed this checklist. So basically the entire team, all the advanced practitioners, the docs, the intensivists, the nephrologists carried around this card, which said based on the result of their urinary biomarker after cardiac surgery, if it's negative, we'll fast track the patient, pull everything out, send them to the floor, they're great. If it's a low positive, we'll keep the Foley in, monitor their urines, avoid nephrotoxins, and use some goal-directed therapy for just that day until 4 p.m. If they don't become oliguric, everything looks great, we pull everything out and send them to the floor. And if it's greater than 0.7 or they become oliguric, their urine output drops, we will use all those mentioned interventions plus some. We will now get an echocardiogram to assess their function, keep their blood pressure higher, keep their mean PAD higher, their filling pressures higher, get a nephrologist involved, and keep them in the intensive care unit overnight. So we aggressively use goal-directed hemodynamic therapy in those patients with positive urinary biomarkers. And what do we find? Well, it turns out that 75% of the patients have a seriously elevated biomarker. So we really then concentrated on 25% of our patients, which were in this over 0.7 group. So that was useful because 75% of our patients could be fast-tracked out of the intensive care unit. And we then looked at the percent of patients that developed stage 2 or 3 AKI. Now remember, stage 3 is the only one that's actually reported to our society for our database, but we looked at stage 2 and 3 because that's really what's considered the most important. And what we found was a significant drop, an 85% drop in stage 2 or 3 AKI with this intervention protocol. So basically, over the course of a year in 450 patients, we had one patient develop either stage 2 or 3 AKI, which is unheard of in a serial exam of all-comer patients. And this was just the goal-directed therapy slide that was part of our recommendation, which was given a class of recommendation of 1 and a level of evidence of B, basically in how to use goal-directed fluid therapy in patients that are identified with positive urinary biomarkers in order to reduce AKI. And the important part that cardiac surgeons have to understand is 2 parts. 1, a transient increase in creatinine seriously reduces your life expectancy, even though it looks great on paper that it came back to normal. Things are not back to normal. And I actually believe it should be a never event. Every patient that goes into AKI after cardiac surgery needs to have a deep dive to figure out what you could have done differently to prevent it. And 2, that an elevation of your biomarker, a stress biomarker, is not injury. That's just stress. And you can prevent the stress from turning into injury by intervention. I'm going to pause right there on AKI and let you guys ask all your AKI questions before I go to my one more thing slide. Is AKI the cause or a marker of mortality? Well, I think the nephrologist would tell us that they don't really know that. But the relationship has been seen over and over and over again that if you have developed stage 2 or 3 AKI following cardiac surgery, your mortality is elevated. Now, one could argue maybe there's some intermediate effect there, and that the AKI was just the representation of that. It's true. I can't prove that, but that is what that's what's thought in the world, is that AKI is actually the cause. Can this biomarker be elevated in cases of fluid overload? Absolutely. Great question, whoever asked that, because that's sort of the advanced question, because everyone says, well, the majority of your interventions, about 80% of the time, was to just give fluid. Don't give Lasix and tank the patient up. But it turns out in 20% of the patients, fluid overload, venous congestion was the cause of the AKI. And those patients require aggressive diuretics. So if we see a patient this morning on rounds with an elevated urinary biomarker, a CVP of 15 to 18, a PAD that's higher than 20, and they are massively fluid overload, I will aggressively diurese those patients, and they will not go into AKI. So it's not just willy-nilly fluid. Most of the time it is. Most of the patients are intravascularly dry and extravascularly full, and you just need to give them fluid on that first post-op day. Then they will mobilize their fluids over the next day, and you just delay it for 1 day. But in 20% of the patients, they are fluid overloaded. Great question. Any other AKI questions? If not, then I'm going to my one more thing slide. Now I'm really I'm cutting into something that Dan really is the expert on, but I can't help myself because of what's going on. So it turns out that I write all the guidelines for the Society of Thoracic Surgeons on COVID, and we actually made the cover last month with resuscitating cardiac surgery. We thought that we were starting up cardiac surgery and the pandemic was over, and this was how to start it up again. Of course, I think we were a little premature in our cover. But that said, I do a lot of reading and a lot of writing on COVID-19, and I want to just tell this very smart audience the one take-home message that I learned and that I'm asked most often, and it's this slide. And actually, it was Amanda Westlake that sent it to me, and she's the one who's explained it to me over and over again. But patients and family members and just family, everybody asks me always the same question, and it's about timing. And they always have the same question. They say, I or my family member was potentially exposed, and I'm going to get a test. And I always tell them the same thing. If they're asymptomatic, all the test tells them really is that there's an 80% chance that 5 days ago they were negative. Because we know this incubation period, if you are asymptomatic and you get tested, the false negative rate is up in the 80% range in that first 1 to 4 days. And it drops way down here by day 5 to 7. So I would encourage everyone to keep that in mind, that asymptomatic testing early after an exposure does not protect you or tell you much of anything at all. Hence, that's why we need to be very careful over Thanksgiving holidays when all these college students come home, because unless they had a negative test a week earlier and also quarantined for that week, they are at risk of infecting everybody at home. But having a cardiac surgeon lecture a bunch of ID docs on this probably is not the best idea. So I will not talk any more about it. And I thank you all for this invitation to speak. I really appreciate it. Thank you, Dan. Questions?
Well, Dan, that was a great talk and something we don't really get exposed to that much, and very interesting. I'm sure a lot of those principles apply to any other type of surgery.
They do, absolutely. You're completely correct. So at other institutions, the lead of enhanced recovery is not cardiac. We're rare that cardiac's the lead. Usually it's the colorectal service or some other general surgical service. So we are just, a strange institution that cardiac is the lead. But it's the same principles. It's absolutely the same, with the only difference being that they use a lot of non-steroidals in non-cardiac surgery in their multimodal. But everything else is the same. You're absolutely right. Very similar. Someone asks, how well adopted are the US guidelines across the US? Do you have a sense of what it will take for other institutions to get fully engaged? So it's happening exponentially now. Everybody wants to get on board because the hospital administrations realize that this actually is a good way to improve value. In other words, lower cost, have less readmissions and better outcomes. So they're all kind of pushing it. So for a while we were barking up our own tree in cardiac anyway, and now everybody wants to have an ERAS protocol program. Pretty much every major institution in the country has an ERAS program for cardiac surgery now, but they're at various stages of rolling out. Some are just working on, let's say, multimodal analgesia. Some are just working on the ambulation or the dietary restrictions. But it's getting bigger and bigger. We used to be kind of the outliers, and people thought we were a little crazy what we were trying to promote. And now our surgical societies have embraced us and invite us to speak at every single meeting because they realize what we're talking about is low-hanging fruit. There's nothing radical here about telling surgeons to use less narcotics. So we have gotten a lot of traction there.
Just a reminder, this will be posted on the hub shortly. So anyone, if you want to look at the presentation again, or if any of your colleagues didn't get to see it, it'll be posted there. Any other questions for Dr. Engelman? All right. Well, thank you, Dan. It was an excellent talk. Very interesting stuff, and that you're working on. Thank you.
I appreciate it. Thank you for the invitation. Thank you for the great questions, and I wish everybody a great holiday and stay safe.